Good afternoon, all. We'll continue on with our spinal cord injury lecture series today. We're going to be speaking about neurogenic bowel management after spinal cord injury. Maybe someone give me a thumbs up if you can hear and see the slides. Thank you. Appreciate it. All right, let's go ahead and move forward. I guess one of the important things to know is that there are new clinical practice guidelines out. They've been out for a relatively a very short time. Essentially, they became available in April. So they will add to what we've previously discussed. We're going to talk through the gastrointestinal tract purpose and function. We will talk through especially the neuroanatomy of the GI tract, including both intrinsic and extrinsic control. We'll talk about normal defecation and GI reflexes because we can utilize those at least with upper motor neuron bowel. And then we're going to talk about bowel care strategies for upper motor neuron versus lower motor neuron bowels. So what is the GI tract for? Essentially to provide fluid and nutrients to the rest of the body. Our daily intake is approximately 800 grams of food and 1,200 cc's of water, or at least fluid. We have about 7 liters of secretions, including those from salivary glands, stomach, gallbladder, pancreas, and intestines. We reabsorb about 1.5 liters per day, so that we excrete approximately 150 grams a day of fecal material. Now, what I really want to do is to focus in on the bowel innervation, because this is especially pertinent to our spinal cord injury patients. So we're going to be talking through, and as we do this, you're going to see all of the tracts that you see in red are basically sympathetic nervous system elements. Those that you see in blue or light blue, those represent parasympathetic efferents in particular, and then the green represents somatic efferents. And this is the only part of the bowel that is under voluntary control. So as we go through this, I want to kind of separate out what is autonomic and what is automatic or intrinsic. So the intrinsic enteric nervous system can and does proceed all on its own. It can function without extrinsic nervous system influence, that is without sympathetic, parasympathetic, or somatic innervation. So essentially the intrinsic nervous system coordinates colonic wall movement. It mixes and locally advances stool through the colon. I'm speaking specifically to the colon because this is the part of the bowel that we can influence with reflexes, but recognize within the colon you have a submucosal plexus, that is Meissner's plexus, and then the myenteric plexus, also known as Auerbach's plexus. And these basically help propel food through the large bowel and propel it forward without any extrinsic influences. Now, I think that we need to step back for a moment and recognize also within the intrinsic bowel or enteric nervous system of the bowel, we have pacemaker cells. The same way that we have pacemaker cells for our heart, we have pacemaker cells in different areas of the gut. And so in the stomach, those pacemaker cells fire at approximately 3 to 5 contractions per minute. In the small bowel, the duodenum contracts approximately 10 to 12 times a minute. And then in the colon, they have very irregular firing, and that is especially influenced by sympathetic, parasympathetic, and somatic nervous system. So recognize that these are all beating, if you will. So these pacemaker cells are beating at different rates. And so the contraction of the stomach is significantly less frequent than contraction of the small bowel. And then as you move into the large bowel, there is, again, a significant difference, and it's very irregular compared to the contractions in the stomach and in the small intestine. So let's talk about the extrinsic innervation. So all of that is intrinsic to the gut. It doesn't need extrinsic influence. The gut can work on its own, the same way the heart can work on its own, but is under influence of sympathetic nervous system parasympathetic nervous system, particularly as we look at the SA node. But we're talking about the gut. So the extrinsic innervation that influences the intrinsic or the enteric GI innervation basically is somatic, sympathetic, and parasympathetic. So the somatic innervation, remember these are the green lines that are coming down below here. The somatic innervation is limited to the pudendal nerve, which comes from S2, S3, and S4, basically to the external anal sphincter and to the pelvic floor musculature. More on that to come. But these are the only elements of the entire GI tract that we have voluntary control over. Sympathetic innervation, and again, this is represented by all of the red lines that are going to the gut here. Sympathetic innervation comes from the thoracolumbar regions of the cord. So there are 22 pairs of paravertebral ganglion, and particularly as we're talking about the gut, you've got superior and inferior mesenteric ganglia, basically coming off from T9 to T12, and then the hypogastric nerve, T12 through L3. Sympathetic innervation to the gut slows it down. Remember, sympathetic nervous system is fight or flight, and you don't want to have GI responses during that fight or flight, or it'll slow you down. So the sympathetic influence on the gut is to decrease the gut motility, to decrease the secretions. And basically it provides tonic internal anal sphincter tone. So it helps to maintain the internal anal sphincter, which is not under somatic or voluntary control. So that comes from the sympathetic innervation. Parasympathetic innervation, remember, arises, and in this, it's from the light blue components of the cranial nerves as well as the sacral nerves. Parasympathetic innervation, remember, is rest and digest. And so cranial portions of the parasympathetic nervous system are particularly with regard to the gut, vagus nerve mediated, and essentially influence the gut from the mouth to the mid-transverse colon. The sacral parasympathetic nerves basically are S2, 3, and 4 mediated, and they take over from the mid-transverse colon to the rectum. So this is influenced or provided to the gut via the pelvic nerve, and the influence of the parasympathetic innervation is to increase motility of the colon, in particular as we talk about the sacral parasympathetic nerves, and to relax the internal anal sphincter. So overall, parasympathetic influence on the gut is to increase peristalsis and gut motility, just the opposite of the sympathetic nervous system influence. It also stimulates secretions and relaxes the sphincters. So defecation. Defecation is that process by which we eliminate all of the things that are going through the gut and are no longer needed by the body. And so defecation is a complex event that occurs under the influence of reduction in sympathetic tone, increase in parasympathetic tone, and voluntary control over the sphincters and the pelvic floor musculature. So as we look at defecation, we also recognize there is cortical influence. We have the ability to recognize sensory information is coming up to the brain. It says, oh, my gut is full, particularly in the lower colon and the rectum, and I need to get someplace to appropriately, socially appropriately eliminate. And so we go through this process as fecal material expands the rectal vault and comes down here. You see a subsequent relaxation of the internal anal sphincter, and it starts to let go. And then it's only the external anal sphincter and the pelvic floor musculature that prevents defecation. And so once you get in a socially acceptable scenario, then you can do that. Now, what is socially acceptable? All of us, when we were children, we probably don't remember this, but went through a potty training exercise. And we learned what was socially appropriately and what was not socially appropriate. And we carry that with us to this day, unless we've had a significant spinal cord injury, in which case all of those things that we learned and are locked in as, automatic, essentially, are lost. And so we have to recognize that essentially all of those things that a person with new spinal cord injury had learned previously is no longer valid and will no longer help them be as socially appropriate. So we're going to have to give them some additional maneuvers and opportunities to be able to maintain continence. How do you maintain continence? The contracted internal anal sphincter. Remember, that's under the influence of the sympathetic nervous system, but also as it is stretched, it actually has, this is one of the situations where you end up with inhibition, so that it relaxes more and more when it is stretched. So the internal anal sphincter tone is inhibited, therefore, by rectal stimulation of the stool, meaning it's going to relax, and you've only got voluntary control over the anal sphincter and the pelvic floor musculature. However, if you have a spinal cord injury, you don't have voluntary control over those. They may be influenced by reflex activity, but recognize that we don't have voluntary control. Typically, we have abdominal control over, or a voluntary control over the abdominal musculature, and a relative relaxation of the puborectalis muscle and external anal sphincter, allowing for defecation. Let's do a quick review on what we're looking at here. Basically, what we have voluntary control over is the external anal sphincter and puborectalis. Puborectalis, under somatic control, pulls and prevents defecation from occurring. When you relax, however, the puborectalis, the external anal sphincter, then you're able to pass stool into the toilet, socially appropriate mechanisms. Recognizing that if the puborectalis and the external anal sphincter have increased reflex activity, however, you may have such tone that you're not able to pass any fecal material through usual defecation, and therein lies a problem. Let me jump past that. So all of you remember this song, Colo Cabana? No, maybe it was something different in your day, but anyway, I want to talk about the colon reflexes. Colocolonic reflex means that as stool enters the colon, it actually causes a reflex contraction of the myenteric plexus, so that the large colon contracts and helps to continue fecal material through the large colon. We have the gastrocolic reflex, which, as the stomach is stretched, basically it causes colon contraction about 30 minutes later. It's a very, very slow reflex, but it is absolute. And so once a person knows what their reflex time is, it's like doing a knee-jerk response. When I distend my stomach, I know approximately 30 minutes later, there's going to be a contraction of my colon, and I might be able to take that as an opportunity to defecate. Rectocolic, similar to colocolonic, basically, this is colonic peristalsis in response to either a chemical or mechanical stimulation along the pelvic nerve. And so chemical, we're going to talk about the use of suppositories and specific types of basically noxious suppositories, as well as mechanical stimulation in the form of finger stimulation to promote a rectocolic evacuation of the colon and rectal vault. Anal rectal, similarly, as you stretch the internal anal sphincter, it's going to relax. And so we have that going for us. The bulbocavernosus reflex isn't part of the GI tract, but it tells us the integrity of that final common pathway, the reflex between when I basically am doing a rectal exam and I'm reaching around, tugging on the gland's penis or pulling on the pubic hair, that elicits a reflex contraction of the external sphincter and pelvic floor musculature. So that tells me, if that is intact, that I have an upper motor neuron as opposed to a lower motor neuron bowel that I'm dealing with. A lower motor neuron bowel, when I tug on the gland's penis or pubic hair, I get absolutely no response. In fact, rectal tone is relatively flaccid and everything can just leak out all the time. So it's important for us to know, and we'll talk more about that as we talk about the physical examination. But we need to know if the person has an upper motor neuron or a lower motor neuron bowel. So how do we achieve continence with spinal cord injury? First off, let's go back and look at what do we know is going to remain intact. So the intrinsic nervous system of the bowel is still there. And so regardless of external influences, we're still going to be able to pass foodstuffs and ultimately fecal material through the gut. Digestion and absorption, in fact, is intact. However, colonic transport is markedly slowed. To maintain continence, the primary muscles that maintain continence include the internal anal sphincter, which is under sympathetic influence. And so as long as I have sympathetic tone, I'm going to be keeping that sphincter relatively contracted. And then recognize that the pelvic floor or the pelvic nerve also has parasympathetic influence on the internal anal sphincter and causes it to relax. The external anal sphincter under somatic control from the pudendal nerve, S2, 3, and 4. Again, typically a person with spinal cord injury doesn't have voluntary control. So when the internal anal sphincter starts to relax, there is no control over the external sphincter, voluntary control over the external anal sphincter or the puborectalis. Remember that previous little film. The puborectalis, if not held tight and relaxes, allows for the passage of bowel through there. And that's via the pudendal nerve. Now recognize that you may have reflex activity going on in an upper motor neuron bowel that gets essentially squirts, basically, fecal material through the external anal sphincter because of relaxation of the sphincter and the puborectalis as well as lever ani. So let's go back for a moment and just remember one of our previous lectures on autonomic dysfunction. Remember, autonomic dysreflexia occurs because of a noxious stimuli below the level of the injury that causes a massive sympathetic outflow and ultimately increases the blood pressure precipitously. Complications of that hypertensive crisis include stroke, seizures, organ failure, and death, all of which are suboptimal. So as we're talking about bowel, recognize that anything painful or noxious within the bowel is going to send afferent information up the cord where it's going to be blocked at the level of the spinal cord injury. You get this reflex sympathetic outflow and subsequent splanchnic vasoconstriction leading to a hypertensive crisis. Increased pressure is sensed by baroreceptors from the cardiovascular system that sends information to the medulla, which ultimately sends information back to the heart and causes a bradycardia. But below the level of the injury, the person remains vasoconstricted. Above the level of the injury, as they try to dissipate the pressure, flushing, sweating, and pounding headache that we refer to as autonomic dysreflexia. So our goals of bowel management. We would like to have a predictable and thorough evacuation. We would like to have the absence and or the control of constipation, diarrhea, and autonomic dysreflexia. We would like to have bowel continence. All of these things would improve the person's quality of life and their patient satisfaction, physically, economically, and socially. So these are essentially the goals of bowel management that are addressed in these new neurogenic bowel guidelines. Now, Kim Anderson, previously an investigator here at the Miami Project, currently at the Cleveland FES program. She did a survey back in 2004 looking at what is the priority for persons living with spinal cord injury. And I bring this up because they asked, of all functions, what is the most important? And they asked this of people with tetraplegia as well as paraplegia. They asked, is it arm and hand function, upper body trunk stability, bladder and bowel dysfunction? Is it autonomic dysreflexia, sexual function, chronic pain, normal sensation, or walking? If we could fix one, what would be the most important thing or your highest priority? And those with tetraplegia said, not surprisingly, I would like to have arm and hand function. So about 50% of those folks. 13% said sexual function. 11% said truncal stability, but about 9% said bowel and bladder function. If I could have bowel and bladder function back 10%, maybe that doesn't seem overwhelming. But if you look at those with paraplegia, about 25% said sexual function. I would like to, that's one of my highest priorities, but their next highest priority was bowel and bladder. And so we're going to be talking about that because it does represent a significant priority amongst our folks with spinal cord injury. So bowel management research includes both preclinical as well as clinical outcome metrics. The preclinical outcomes include looking at the enteric nervous system, fecal analysis, whole gut transit studies, motility studies, and then colonic smooth muscle tension recordings. Again, this is in the animal models primarily. Clinical outcome metrics include some of those same things, but in the form of bowel diaries, physical exam and laboratory findings, imaging, endoscopy and colonoscopy, gastric emptying studies, including total and segmental colonic transit time, using wireless motility capsules, anal rectal manometry, what kind of pressure is generated within the bowel, and then pudendal nerve conduction velocities, pelvic floor EMGs, to try to determine how to have better control over incontinence. And then subjectively, this is a little different than what you see in the animal models, where you can't really ask the animals, how do you feel about this? Subjectively, in clinical trials, the Qualavine 30 and short form Qualavine are used, as well as a neurogenic bowel dysfunction score. And these are metrics that are recommended to be employed as we're looking at bowel management research. So we need to talk about the Bristol stool scale. How fun is this, right? It is so important for our clinicians, particularly the nurses and the physicians, to know how the fecal product looks, how the stool products look. So if you have rabbit droppings, so this type of a scenario, separate hard lumps, this is indicating constipation. It's indicating that the person is not having enough fluid or enough stool softeners as they're going through that. If it looks more like a bunch of grapes, then these may be sausage shaped but lumpy. If it looks like corn on a cob with cracks in the surface, that's also not good. If it's a sausage looking that's smooth and soft, that's kind of our ideal. That's what we would like to see as we go through there. Chicken nuggets, maybe. It looks like soft blobs with clear-cut edges. And then we're talking about porridge or gravy types of scenarios. So this is actually, these are not stool products, by the way. This is actually a cake that was made as they were sending off one of our clinical nurses into retirement. But anyway, this is still representative of how we should be reporting fecal material and stool products. And that's going to be important for us to know how to manage appropriately as we come through there. Now, bowel care equipment includes typically a padded bedside commode, and or the person may need stimulators, hand stimulators as well. We'll talk about why in a few minutes. And for those with higher levels of spinal cord injury that don't have good truncal balance, that don't have good hand control, and that would benefit from tilting, this type of a bowel commode chair is going to be most appropriate and actually required for most folks with tetraplegia in order to get a good emptying. So let's talk about the neurogenic bowel from an anatomical and a physiological perspective, recognizing the two main types: an upper motor neuron bowel, which is hyperreflexic, or a lower motor neuron bowel, which is hyporeflexic or flaccid. Because we're going to have different ways of managing an upper motor neuron bowel that we can take advantage of all of those reflexes, as opposed to a lower motor neuron bowel where we're going to be pretty much relegated to passive evacuation. So for an upper motor neuron bowel, remember, an upper motor neuron injury basically brings you to a position where you have the inability to control your spasticity and inability to inhibit reflex activity of the pelvic floor muscles because of disinhibition of those supraspinal inhibitions of all of our reflexes on the way down the cord. Defecation is not voluntary when you have an upper motor neuron bowel, and yet the reflex sacral arcs between the cord and the colon remain intact. And so again, we can take advantage of what we know about those reflexes. So how do you do an upper motor neuron bowel program? Having the person upright on a commode if possible, because you want gravity to work on your behalf. Having a diet high in fiber and approximately 2 to 3 liters of fluid a day. Remember, that's going to be limited by your bladder management, and you don't want to be having too much fluid, because then it would increase your bladder volumes, leading to autonomic dysreflexia, leading to inhibition because of the sympathetic tone on the colonic tract. So the use of contact irritants, suppositories, and digital stimulation. Timing is going to be 30 to 60 minutes after a meal to optimize the gastrocolic reflex. Now, this part I have to put a caveat on, because the new guidelines actually don't suggest using Valsalva and abdominal massage or weight shifts. And why is that? We just don't have the literature to support their efficacy. On the other hand, not sure that there are side effects associated with those unless the person is so vigorous that they would cause a noxious stimuli below the level of the injury and lead to autonomic dysreflexia. So keep in mind, there's a caveat on this with the new guidelines. Frequency is typically, we're going to start this daily until the person has regular emptying and mucus material showing up without fecal material. Then we can move to an every other day frequency. Ideally, we're going to decrease the bowel program time and decrease fecal incontinence and retention of stool in the lower vault. The stimulation, the digital stimulation that goes along with this irritant component. So the person has a gloved finger with appropriate lubrication jelly on it, inserted into the rectum, and basically using a circular motion of the finger and the wrist, applying gentle pressure to the bowel wall 360 degrees for about 20 seconds. And you repeat this every 10 to 15 minutes after the suppository had been inserted. The whole program should not last over an hour, and under the most appropriate conditions typically will be over within 30 to 45 minutes. Again, abdominal massage weight shifts may be used but are not advocated by the current guidelines. And always do the bladder evacuation before the bowel program. Why is that? Again, a distended bladder can cause the noxious signals ascending the cord, reflex sympathetic outflow that slows the colonic transport. So empty the bladder first so that you don't have to be fighting against a sympathetic outflow that is unnecessary. So quick set orders are available for the residents, and I hope that they're using them. Basically, this is the way that I'm recommending that we put orders in for an upper motor neuron bowel program in acute rehab, having the person upright on a padded commode, if at all possible. Otherwise, lying on the left side is going to optimize evacuation. But again, upright allows gravity, and it also positions the sphincter in the most likely way that it's going to open and allow for passage of fecal material. Using a daily bisacodyl and polyethylene glycol suppository, this is also known as a magic bullet. This is a water-soluble base, so it allows for relatively quick melting. And then the bisacodyl, which is essentially a caustic substance, will cause a chemical reflex contraction of the colon we talked about earlier, followed by digital stimulation for up to 30 seconds every 10 minutes, up to 1 hour. Again, trying to get the whole program done in a relatively short period of time. Nobody wants to spend 3 hours a day emptying their bowels. That would be incredibly frustrating for you or I or anyone else with an intact nervous system. For persons with spinal cord injury, they don't get any less frustrated. And because of the likelihood of having incontinence, it's actually more distressing to them. So ideally, performing this 10 minutes after a meal, 30 minutes after a meal, and recognize for those with T6 spinal cord injury, the process of using the suppository and digital stimulation can cause autonomic dysreflexia. And so if we are consistently having that using the bisacodyl polyethylene glycol suppository, we may need to switch to a different format, including enemies, which is a mini suppository. I'll talk more about this as we get to pharmacological discussion, or enemies plus, which has an anesthetic gel to it as well, like lidocaine, basically to reduce the chemical noxious stimuli and have a more gentler approach that doesn't cause autonomic dysreflexia. It may be necessary to switch over even to a glycerin suppository, which has no essential elements to it, but can still be helpful to help stimulate bowel contraction. And then the bisacodyl and vegetable oil suppository, the usual Dopalax suppository, I really don't like to use that. It takes usually 3 hours for it to melt. And as I said, that's not going to be a very effective program as we're going through there. So again, the caveat on this one, abdominal massage and weight shifts, not necessarily beneficial according to the new guidelines. And yet, I would say that for some individuals, they're very effective. You do need to make sure that these things are not contributing to autonomic dysreflexia. So once daily bowel care results in no stool, so you're doing it every day, and I just did it yesterday, had a great response today, all I'm getting is mucus. Then we can decrease the frequency to every other day, because it means that you've completely emptied the rectal vault. The only thing left is the mucus in response to your chemical and digital stimulation. So what about the lower motor neuron bowel? Now remember, this is a situation where, like musculoskeletal spasticity, the anal sphincter, external anal sphincter, the pelvic floor musculature is flaccid. So it's paralyzed and it's flaccid, it's not spastic. And so this is a situation, your mesenteric plexus is functional, but you don't have spinal cord mediated reflexes. And so you're going to have significantly low tone in the external anal sphincter and the pelvic floor musculature. This person is at risk for having frequent incontinence unless we modify their bowel care program somewhat. Now, one point early on in the course of a upper motor neuron spinal cord injury, the person may be in acute spinal shock, which looks like a lower motor neuron injury in that they don't have their reflexes recovered yet. And so they may appear to be a lower motor neuron bowel, and during that time, they're going to have reduced reflex-mediated bowel evacuation. We do anticipate that this would resolve and that the person would have reflex activities, those with an upper motor neuron bowel, not those with a lower motor neuron bowel. So This is the execution of the lower motor neuron bowel program. Again, pretty much everything that we listed here, except we do not use contact irritants or digital stimulation because those reflexes are not present. This is a lower motor neuron bowel. We still want to go 30 to 60 minutes after a meal. The Valsalva, abdominal massage, weight shifts are not recommended in the most current guidelines, but may be helpful for some individuals. Frequency is going to be daily, and this is pretty much going to be routine, and I'm going to stick with the daily program so the person doesn't have incontinence. Remember now, they have a flaccid sphincter. They have a flaccid pelvic floor musculature, and so they're likely for leaking out. So what we're going to be trying to do here is to have a little bit firmer bowel care product or stool product, and to try to reduce fecal incontinence, and making sure that we're removing stool from the rectal vault. So what does the lower motor neuron bowel program look like? The quick set orders for the residents. This includes daily digital disimpaction, typically upright on a commode. Again, using gravity, we can still use that for us. Ideally 30 minutes after a meal because the gastrocolic reflex remains intact. Encouraging abdominal massage, weight shifts, not so much according to the new guidelines, although may be helpful for some individuals. And then again, document the results, including the stool amount and the consistency. Very, very important for us to know, to be able to arrive at what we're looking for. What are we looking for? Ankoprisis prevention. Ankoprisis is bowel incontinence. And so we're trying to prevent the person having a bowel accident. And we're going to be assessing the program, whether it's upper motor neuron, lower motor neuron, or a mixed type of a picture. We're still going to consider these things. We're going to be looking at diet and fluid intake, making sure that we have appropriate fiber. But if you're going to be taking supplemental fiber, you need to make sure that you have an appropriate fluid intake, or you'll end up with constipation. Protein and high-fat diets can stimulate bowel movements. And so somebody who likes to go for a greasy burger every once in a while is going to have likely incontinence associated with that. So recognize that if that's a plan and you just got to have it, you're going to have to modify other components of your bowel program, maybe decreasing your fluid intake somewhat, or increasing the frequency of your bowel care so that you don't have a bowel accident. The more active an individual is, the better the GI tract works, period. And so bed rest, lying around, not getting out and about, even the bumping up and down in the power wheelchairs as they're going over sidewalks and whatnot, that all contributes to GI motility. And so I do increase activity because I think that it helps to improve overall gastrointestinal motility. Now, the time of day is going to depend upon the person's other habits. So some folks want to do this early in the morning because they're going to go to work all day, et cetera, et cetera. Other folks would like to do it at night. And so long as we regulate the program and they're not having incontinence, that can work well for them as well. Might depend on who they have available to them to assist if they need assistance. So the frequency is every 2 to 3 days for an upper motor neuron bowel and daily for a lower motor neuron bowel. Positioning, we talked about, ideally upright, seated on a padded commode. That's a better response than the person lying on their left side, which is a better response than them lying on their right side. So the duration, we want to have this less than an hour. And the characteristics of the stool, we're gonna talk through basically, but if you're seeing only mucus, then you don't have to go as frequently with your bowel care program. We're going to use medications as necessary to make sure that we have the appropriate consistency, and this includes stool softeners as well as stimulants. And if I'm going to make a change in a person's bowel care program, I will just do one thing at a time. I don't try to change everything all at once because then I don't know what worked. And rather than interrupt their entire routine, we would like to find out which part of their routine can we change. So the efficiency of assessment is going to be very, very important as we go through this. Now, my physical exam is going to be very important. Obviously, I listen for bowel sounds, palpate along the colon. The rectal exam is going to tell me if the person has an upper motor neuron or a lower motor neuron bowel. Part of that is by sphincter tone. If I have no tone, then I'm likely either in spinal shock or I have a flaccid lower motor neuron injury. And then I'm going to look for an anal wink, which tells me that I've got at least some cortical influence still intact. But the bulbocavernosus reflex, again, tugging on the glans penis, you see afferent input coming back to the anal sphincter, and it should close down around my finger as I'm doing the rectal exam. That's the BCR. That tells me if I've got an upper motor neuron bowel. Now, if we take a look at, excuse me just a second here. If we take a look at pharmacological management, basically we've got fiber bulking agents that increase the bulk with increased water reabsorption, and there's a number of things that we can use. It really is an individual selection kind of process as they go through this. Some people don't like the grit and or the flavor associated with Metamucil, for example. Some folks like the FiberCon or Benefiber, which are tasteless, colorless, odorless substances. You need to make sure whatever you're using as a fiber supplement that you're taking sufficient water in, or you will end up constipated. Stool softeners, in addition to that, emulsify fat and decrease the water that's reabsorbed. That is, they increase the water content of the stool. And these include the different preparations, whether it's sodium, calcium. Docosate sodium is cholase, docosate calcium is surfact. It doesn't really improve the bowel transit or peristalsis, but it does soften the stool. And then lubrication, obviously, or maybe not so obviously, but I'll just tell you, it needs to be used. Lubrication, Surgilube or KY jelly for all individuals when you're doing the digital stimulation. For those with autonomic dysreflexia or high risk for autonomic dysreflexia, using lidocaine gel, such as Anusol or Nuprocanol jelly, is necessary to prevent that really robust and subsequently hypertensive response. Additionally, consider laxatives, but use these very sparingly. So the use of salts, including magnesium citrate, milk of magnesia, not mild of magnesia, milk of magnesia. The use of these electrolyte products can cause abnormalities and ultimately a lazy bowel. Sugars can be used, such as lactulose or sorbitol. Again, can contribute to electrolyte abnormalities and a lazy bowel that does not respond except to this type of a process. Polyethylene glycol, again, using this sparingly. This is also used in bowel preps. Miralax, Go Lightly, these kinds of things, again, can contribute to a lazy bowel. Occasionally are necessary just to help jumpstart the bowel. And then Senna. Senna typically is used within the first 3 to 6 months after a spinal cord injury, but I like to wean folks off of it after that because of the complications that occur, including melanosis coli. That is an atonic bowel, a lower motor neuron bowel. This affects the intrinsic nervous system or the enteric nervous system and actually causes flaccid enteric nervous system. So things to keep in mind. And then what about pro-motility agents? No matter what we're doing, it just doesn't seem like things are moving through. These agents are to promote gastric and colonic motility. So bethenacol, urocholine can be used off-label and may be helpful. Remember, these are muscarinic cholinergic agonists. Anticholinesterase inhibitors, such as neostigmine, can be very, very helpful. Mark Corsten has demonstrated significant benefit with these, but realize that this may be associated with cardiac arrhythmias, bronchospasm, and drooling. So if you use this in conjunction with glycopyrrolate, which is a selective anticholinergic, it blocks some of the mechanisms. This can promote bowel evacuation without those cardiopulmonary side effects. Other prokinetic agents to consider, tegocerod, so Zelnorm, basically no longer available. It is being used in some testing protocols with the FDA, but has otherwise been withdrawn. Metoclopramide, so Regland, is a cholinergic agonist, also a dopamine antagonist that increases gastric but not colonic motility. So probably isn't helping the way that we would like to. And the side effects include dystonias, those extrapyramidal side effects associated with that, as well as sedation. And then you don't want to use this in conjunction with antidepressants or MAO inhibitors. Cisapride, Propulsid, is going to have an influence on the myenteric plexus, but this has also been withdrawn by the FDA because of side effects, particularly putting people at high risk for Torsades points. Consider using mu-opioid receptor antagonists for those who are on opioids. So Relistor, that's methyl naltrexone, and naloxegol, Movantik is the other name for this. Also consider, and it's been pretty effective, is erythromycin, which somehow stimulates the motilin receptors in the upper GI tract. So these are all considerations for pro-motility for those folks. It's just not moving through appropriately, and you've tried your other interventions. Now, pharmacological management also includes those contact irritants. So in addition to digital stimulation, suppositories, that the chemical response of those suppositories can stimulate peristalsis in the lower large bowel. So bisacodyl, again, you have two preparations. One is the Docolax, which is in a vegetable oil base. Takes about 3 hours to melt. And then the Magic Bullet, which takes about 1 hour to melt. So this is a much better product. Glycerin suppositories can be used if you're having autonomic dysreflexia in response to these. You can also consider the Enemies product, which is docosahexaene sodium, polyethylene glycol, and glycerin, or the Enemies Plus, which also includes benzocaine. I try to stay away from, except in rare instances, stay away from fleets and soap suds enemas because they leads to essentially a lazy bowel. And then smog is another consideration. Usually only use it, again, rarely, in those circumstances where somebody appears to be very constipated. We'll talk about some of those things in a moment. So saline, mineral oil, and glycerin, 50 cc's each in a 1 liter prep. So other bowel management options, and this is what you would use for folks who have intractable constipation and impaction, or a lot of fecal incontinence, and or increased bowel time. It's just not working. Consider transanal irrigation. So this is a retrograde enema using a rectal catheter, inflatable balloon. So this is this type of a system here. Basically, you're flushing forward as you go through there. I'm sorry, you're flushing backwards. So you put this up from below, and it causes emptying in that respect. You can do surgical procedures. So this increases or improves the bowel time, so it decreases the total amount of time needed for your bowel care program, reduces the need for medications, and in some cases reduces morbidities. That would include a colostomy. Recognize that the persons should have a psychological evaluation prior to this type of an intervention because of psychosocial implications. The other procedure that I was talking about that I shouldn't have said, but is the antegrade continence enema. And this is where you're actually using the appendix to essentially create a catheterizable stoma, and then you're pouring this through in a retrograde or an antegrade fashion. So this was initially trialed in children with spina bifida and myelomeningocele. It's also been very effective with lower motor neuron valves. I don't know that we have anybody here in Miami doing this at the moment, but this is has been met with a fair amount of success in some of my previous institutions. Using functional electrical stimulation, I've talked about this before and I'll speak about it again, to stimulate bowel contraction. And so you have systems not available in the United States, unfortunately, anymore. There was a device called Neurocontrol, basically, but it's not commercially available. There is a product, the Brindley stimulation system in Europe that is used and continues to move forward. But right now, the only utilization of this is with ongoing clinical trials. It's not commercially available because there aren't enough people who use it. There are bowel complications that occur after spinal cord injury, and these are what we're trying to prevent. So the bloating and abdominal distension in more than 50% of individuals. 50 and I'll say to 60% of folks with spinal cord injury will develop hemorrhoids. And some of those you can manage just with steroid cream. They may need to be banded and or surgically repaired. Do they reoccur? Yes, but oftentimes after a surgical procedure or banding, they don't present the noxious stimuli that they did before. And so really we use this treatment strategy for those folks who have significant autonomic dysreflexia. And about 13% will develop recurrent fecal impaction. So constipation is one of the major things that we end up dealing with, where you have a decrease in frequency of bowel movements with hard stools, spastic anal sphincter, and particularly pubo rectalis contributes to this. So there are morbidities that we worry about, and also recognize that an appropriate assessment and workup needs to be done as you move through this. A more complicated component of this would be called obstipation, which is obstructive constipation. And basically this prevents passage of stool or gas. Symptoms include abdominal distension and bloating and dehydration, malaise, nausea, and vomiting, and autonomic dysreflexia. Obviously that needs to be treated immediately and then worry about these other things as we go through there. So the typical treatment to manage these folks is going to require volume resuscitation with IV fluids, a nasogastric tube to try to decompress the upper GI tract, progressive bowel care, including vesicodal suppositories, digital stimulation, and an enema. And it may require surgical consultation. So diarrhea, the most common cause of diarrhea after spinal cord injury is constipation. You end up just pouring fluid around the blockage, if you will. So the cause is typically an inappropriate bowel care program. They may have an overdose on fiber, for example, with not enough fluid. They may also have antibiotic-induced diarrhea, such as you see while trying to treat certain infections. You may also get diarrhea attributed to C. diff colitis. Spicy foods and caffeine, as well as greasy foods, are going to contribute to diarrhea as well. If you have a bloody diarrhea, recognize that this is probably not just an intake issue. This probably represents an infection. So I know that I'm running short on time. Basically, other serious complications, probably the most serious is autonomic dysreflexia, and we've talked about management strategies for that. We've talked about a few more of these. We really don't know if there's an increased cancer risk in persons with spinal cord injury. The data that we've seen seem to indicate that they're not at a higher risk, but it's really difficult to do colonoscopies on this population. Dr. Paik, one of our GI internists that serve both UHealth as well as the Jackson system, is using a better bowel prep that is less invasive, and so we're hoping to utilize his services to a greater extent in the future. Our folks generally have an increased risk of ulcers, cholelithiasis, and GERD as well after spinal cord injury. And then finally, we worry about incontinence leading to social paralysis. We want to, as much as possible, prevent ankoprisis. Obviously, if we can do that, then we can get people back participating in work and normal activities. Education, 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 and then assessment is required. So these are my updated references. Happy to answer any additional questions that may have arisen. I'll stop sharing my screen. Any questions, thoughts, concerns? And hearing none, I'll go ahead and leave you then for this week. Our next meeting will be discussing neurogenic bladder, which is pretty much a correlate to the neurogenic bowel. So everyone have a wonderful week and be thankful that you have good control of your GI tract.